What's up, guys? Victor here from UIC EMS. We're going to break down a traditional normal delivery of a newborn, as well as some abnormal presentations and complications. We're going to go over the OB kit, but just as a reminder, just follow your local protocols. We are coming from a pre-hospital EMT background, so if there's anyone out there with an OB expertise, feel free to chime in and add on to this explanation. And so every ambulance is going to have kind of a pouch or a case as an OB kit, and kind of on this side of the table we have the stuff within that OB kit laid out. So we'll have chucks around to place under the patient to absorb the fluid, and these chucks can double as puppy training pads. We have surgical sponges, more absorbent pads, sterile gloves. We understand that pre-hospitally, we were in the field, this is not typically a sterile procedure, but we want to be as clean as possible. We'll have an OB pad for the postpartum hemorrhage. We have a bulb syringe, which you're going to push in with your thumb to utilize that suction power. We'll have a scalpel, very sharp. Do not play Fruit Ninja with this, but this is going to be used to cut the umbilical cord. We'll have two clamps, umbilical clamps, to clamp the cord, and you should have blankets or bunting blankets for the baby, to keep the baby warm. We also have two types of wipes, one alcohol based and then one non-alcohol based. And so let's talk about what scenario would present to you in order to utilize this OB kit. You're dispatched to the residence for the OB and labor. You show up, scene is safe, ABCs are great, mental status is ANO times 4, but the patient is in visible distress. You want to ask the patient how long the labor has been going on, how long her contractions have been going on, but more importantly, how long do they last and how frequent do they come? And so if we were to put a number on it, if they come every 2 minutes and if they last as long as 90 seconds or a minute and a half, we really don't want to start racing the baby. We want to ask a few other questions, like, has your water broken? In medical terms, that would be, has there been a rupture of membrane, ROM? How many pregnancies have you gone through and how many deliveries have you experienced? So gravida and para. And so with that being said, if they've been pregnant more often in the past, the current labor is going to be shorter and faster. And so in addition to that, another criteria that can help us make this decision of stay and play or load and go is ask the patient, does she feel the urge to push? And so if the baby was truly crowning, she would have that urge to push. But that being said, and correct me if I'm wrong, it's probably very subjective, but if the patient has been pregnant previously and delivered multiple births previously, this crowning, she might not feel it. So you have to take it upon yourself to visibly identify if there is crowning. And so the patient would drop the pants, and if you see this type of bulging, we really don't want to race the baby to the hospital. If I had to choose delivering a newborn within the back of the ambulance or within the patient's home, we would always choose the patient's home. And so if that was the case, I would tell my partner to go grab the OB kit from the ambulance, and we're going to set up shop. We're going to make mom super comfortable on the ground or on the bed, on the couch, because if we were in the ambulance and this was the ambulance, this table was the ambulance, and the patient was typically like this, they'd probably be perpendicular to the stretcher with their legs on the bench. And where the camera woman is, she would be the EMT facing the patient. And so if we could choose, we would rather be in the patient's home. And so if the patient is crowning, typically as another wave of contractions come, we want to try to clean the site as fast as possible. And I want you to imagine, if you had a paper cut, would you rather use an alcohol-based prep pad or a non-alcohol-based prep pad? And so if you had a paper cut right here, which one would you prefer? And every time people end up choosing the non-alcohol based pad. And another question is, like, how do you want to wipe it? Do you want to go aseptic techniques, small circles to larger circles? Are you going to go zigzag? Are you going to go front to back to front? And the thinking with this is, as the patient is pushing, she's not only pushing the baby, but she's pushing feces out as well. And so we don't want to introduce that feces back to the baby. So we want to do front to back and use a clean part of the towelette every time. And so it's been another 2 minutes, another wave of contractions is coming. In real life, we don't really do this, but we're going to unsnap the vagina, and as the baby's head comes through, we really want to see if the umbilical cord is wrapped around the baby's head. And so if the umbilical cord is wrapped like a noose around the baby's head, that's what's called a nuchal cord. And so what we can do, the umbilical cord is typically very slippery with amniotic fluid. We want to take our gloved hand and we want to try to slip the umbilical cord over the baby's head. And if we're unable to do so, then we're going to clamp the cords right then and there, make sure that there's no pulse between the clamps, and then you're going to cut the cord right then and there to relieve the baby. If there is no nuchal cord, the widest part of the baby is going to be the shoulders, and so we want to assist the baby onto its side, and we're going to provide a seesaw motion. So another wave of contractions is coming, and we're going to provide a seesaw motion. That seesaw is going to be down and up, down and up, down and up, and then once the shoulders are free, the baby's going to be free from the vagina. And the last thing you want to do is you want to present the baby like Simba to mom, like, "Mom, look, baby's looking great." Because as you elevate the baby above the placenta, the circulation is going from the baby back into the placenta. So what you want to do is you want to maintain the same height, same level from the baby to the placenta. So don't cut the cord just yet. If you see any secretions or mucus in the airway, we're going to take our bulb syringe, and because babies are obligate nose breathers, we don't want to stimulate the nose first. So when I say obligate nose breathers, that means that when you stimulate the nose, it's going to stimulate them to take their first breath. And so we're going to clear the mouth and then clear the nose, and then that should prompt them to take their first breath. At that point, we should be taking our first APGAR. So it stands for APGAR. Total number of points is 10, minimum of 0. So I'll let you guys Google that. But at this point, we can start to clamp, apply the first clamp. And so that first clamp is going to be about 6 inches away from the baby, and 6 inches is about the shaka in Hawaii. So we can apply the shaka to the baby and apply our first clamp at that site. The second clamp will be applied about 2 inches away from that first clamp. Now, before, just for explanation's sake, before we cut the cord, this is very slippery and probably not very clean right now. We want to use the alcohol prep pad to clean this umbilical cord. And alcohol has a drying effect, and so we want to dry this cord as well. Before we take our scalpel, we're going to palpate the cord. When we palpate the cord, we want to make sure that we don't feel a pulse. If we feel a pulse and we cut, we've just created another source of hemorrhaging. And so you want to palpate, ensure that there's no pulse. If there is, apply additional clamps outside of the primary clamps. And so when you cut the cord, part of the cord is going to go with the baby, and the other part of the cord is going to go, still be attached to the placenta. Refrain from trying to play tug of war with this umbilical cord. The placenta should naturally deliver on its own between 15 to 20 minutes without our help. So refrain from playing tug of war with this. Allow the mom to nurse the baby as well as provide a fundal massage. So the fundus is going to be the top of the uterus. And so we would just apply a fundal massage to the top of the uterus, and those two things will promote hemorrhage control for the mom. And so that was pretty much a traditional delivery. The other thing I wanted to mention is before the suctioning, if you noticed a brownish greenish tint to the amniotic fluid, that will indicate the presence of meconium. And so that tells us that the baby was in distress and that the baby might have soiled himself within the womb. So we don't want the baby to aspirate that into their lungs. So that was a traditional one, and I wanted to also preface that we are assisting with this. We're not doing the pushing, we're simply doing the catching. So don't freak out if you're called to the OB in labor. The mom is doing the work. We are gonna go over a lot of abnormal presentations, but primarily, more often than not, the delivery is gonna be normal, okay? And so let's go over some abnormal presentations. The first one, we've already gone over nuchal cord, but the second one is going to be, if you check for crowning and you saw this, you saw the umbilical cord protruding out through the vagina. So this is called a prolapse cord. What we want to do is we want to take our gloved hand and palpate the prolapse cord. If we feel a pulse, we can take a piece of gauze, moisten it, and cover that. And now that's going to be part of our reassessment. We're going to reassess that every 5 minutes. And if the pulse disappears, that tells us that there's no circulation being received to the baby. And so to alleviate that, there are 2 instances where we insert pretty invasively our fingers into the vagina. And in this case, we're going to look for the baby's head, because our thinking is that the weight of the baby is pushing down on the umbilical cord, impinging on its circulation. So we want to find the baby and kind of push it off of the umbilical cord until the pulse returns to the umbilical cord. So that's prolapse cord. And you're going to have to maintain that probably until the destination. The next presentation is going to be either 1 foot or 1 hand. And so if it's 1 foot or 1 hand, this is called limb presentation. This is, they are unable to deliver this baby vaginally. So they need to be rapidly transported in a knee to chest position. And when I say knee to chest, if this was the patient's knees would be up to their chest, kind of closing the exit door for the baby. And so refrain from giving the baby a high five or pushing the limb back in. That's a big no-no, okay? So that's limb presentation. The next one is going to be breech birth or breech presentation. So breech will be 2 feet over the butt, and this is actually able to be delivered vaginally. Now, it would be pretty smooth. We would have the patient on all fours instead of on their back to allow gravity to assist the delivery of the baby. And the complication will come if the baby's head gets stuck inside and it decides to take its first breath. So if it gets stuck inside, this is going to be the second instance where we want to invasively insert our fingers up into the vagina. And we want to create a pocket for the baby to breathe in case they take their first breath. We only do this if the head is stuck. If the head comes out, then we're okay, all right? Everything's gonna be okay. The next one is, let's say you're called for the vaginal bleeding. You end up going through ABCs. ABCs are okay. And you ask the medical history and you find out that the patient has a medical history of placenta previa. They would know this if they've been going to a prenatal doctor. So they have placenta previa, they have vaginal bleeding, and your thinking should be the weight of the baby is pushing down on the placenta. They will not be coming through the vagina on their exit. They're gonna get a C-section for this. The difference between this placental abnormality and the next one is going to be the presence or absence of pain. And so the other one, the placenta is in a normal area at the fundus, but this is going to be prompted by trauma. And so if the patient recently suffered, let's say someone opened a door on their belly, they got into a car accident, they fell down, they tripped on a sidewalk and landed on their abdomen, there could be a partial or a complete tear, premature tear or abrupt tear of the placenta from the uterine wall. And so this would cause vaginal bleeding as well as abdominal pain from this. So this is with pain, and placenta previa is without pain. So this abruptly tears, and then this one is the placenta comes previous to the baby. So that's kind of what I use to help remember the differences between the two. And I think that's it. Like, comment, subscribe.